Hello, everyone. Happy Wellness Wednesday day. We I hope everyone's doing well and staying safe and trying to stay dry in this rainy weather that we have today. And what a better time to be inside in our offices, um, viewing a virtual Wellness Wednesday session on a very interesting topic. And I will also add a commonly requested topic that it's been requested by you, our members, giving us feedback on our surveys, I would say for the past 4 years. So we're glad to all of you who've been able to attend today. This topic is thyroid health, and we are so honored to have Dr. Brian Grissett, who is an endocrinologist with the Florence Endocrine Clinic, and they are located on Anna Drive. There's also another endocrinologist in there with Dr. Grissett as well. He's been there for about a year and a half, I believe he told me. And he's originally from Gadsden, Alabama. He completed his medical school at the Philadelphia College of Osteopathic Medicine. And that was followed by an internal medicine residency in Huntsville and endocrinology fellowship in New Orleans. He is very well equipped to address a wide range of endocrine concerns, and his special focus areas are diabetes management, hormonal imbalances, and thyroid disorders. So we're just so honored that he could take time out of his busy schedule and be with us today. Before I turn it over to him, I noticed in our chat we do have people coming in and saying, typing in RFW. If you'll just continue to do that as you enter the chat, and then we'll record your attendance. All right. Without any further ado, I'm going to turn it over to you, Dr. Grissett.
All right. Well, good afternoon, everybody. Appreciate y'all inviting me to give this talk. I'll switch over here to the presentation. I assume everybody can see the the PowerPoint with heart to heart about the thyroid. That was my attempt at being clever, since it is apparently Heart Awareness Month. And we'll talk about how the thyroid gland essentially interacts with the heart and influences cardiac function. As we go through the presentation, we'll do a brief primer on how the thyroid works, the hormones that it secretes, and the downstream effects of some of those hormones. And then we'll talk as well about what happens when a wrench gets thrown in the works there, whether with hyper or hypothyroidism, some of the most common causes of those conditions, and briefly on the treatment of those conditions. And again, we'll go in depth as to what symptoms are typically experienced, and we'll press on from there. So first, about the anatomy of the thyroid. It's a butterfly-shaped gland that typically sits right below the thyroid cartilage, which is kind of the Adam's apple that you think of on the neck. It releases thyroxine, or free T4, as well as T3, which are hormones that have a great impact on multiple organ systems through the body, including, of course, the heart, which we'll focus on today. And the symptoms that these disorders can cause can put great strain upon the heart or cause it to operate more inefficiently. And we'll talk a little bit more in depth about how that pathophysiology works and what we can do to promote awareness of that, and hopefully provide treatment for folks sooner rather than later, when a lot of those cardiac complications can occur. Before we press on, it is important from a physiology standpoint to have an understanding of how the body communicates with the thyroid. And there's this axis that's present where these different structures communicate with each other. In this case, the hypothalamus up in the brain will communicate with the pituitary, which is another endocrine gland located in the brain, which in turn releases hormones that stimulate the thyroid. Now, specifically, the hypothalamus will release TRH, or thyrotropin releasing hormone. Very descriptive terms here for these hormones. TRH then, of course, goes to the pituitary right next door below the hypothalamus, which stimulates the pituitary to release TSH, or thyroid stimulating hormone. The other name for that is thyrotropin, thus, you know, providing logic for why TRH is named the way it is. Now, TSH is extremely important. That's actually our main benchmark hormone that we use for measurement and determining the presence of hyper and hypothyroidism. And we'll talk about how that works. It's important to understand this relationship because it provides a lot of clarity and insight as to what different TSH levels indicate in terms of hyper and hypo. And it's a little counterintuitive unless you understand this physiology behind the scenes. That TSH in turn does travel from the pituitary down to the thyroid and stimulates the thyroid, as the name suggests, to produce T4 and T3. So a little bit about T4 and T3. T4 is essentially a prohormone reservoir. So it's essentially available in the bloodstream, largely bound to thyroxine binding globulin, and can be freed from TBG or thyroxine binding globulin whenever the body needs more of that thyroid hormone present. That can be important because there are situations where you may, due to sickness or surgery or some other sort of extreme physiologic stress, lose temporary function of the thyroid gland. And because of this reservoir, you'll still be able to have enough sufficient hormone for a few days anyways. But that T4 does get converted to T3. The reason that it's T4 and T3 is it relates to the number of iodine atoms that are attached to the molecular skeleton there. And you can see I have a red arrow there pointing to the one iodine that gets removed to convert it to T3. Now, T3 is much more biologically active, has a much higher affinity for going into the nucleus of the cell and causing the downstream effects. So that's largely, again, the active form of the hormone. And then, of course, as we mentioned earlier, any disruption to the production of these hormones, whether too much or too little, can have far-reaching complications on multiple organ systems. But again, we'll be focusing primarily on the heart today. So with that focus, if you do have an excess of thyroid hormone, which actually we'll talk about that in more detail later, but the thyroid hormone will influence how fast the heart is beating, which in turn will affect blood pressure and also has an effect on vascular resistance, which means not only on the heart itself, but on the blood vessels down the way. If you don't have enough thyroid hormone, then that can cause a vascular stiffening and cause blood pressure to be out of whack as well. So we'll start off with hypothyroidism in terms of the thyroid dysfunction. In essence, what happens when you don't have enough of that thyroid hormone present in the system. Now, I hearken back to that hypothalamic pituitary thyroid axis because what actually is the hallmark of hypothyroidism is having a high TSH. Now, if you're looking at your blood work from the doctor, you might see a high TSH and know that TSH is involved with the thyroid, and it may make sense and think, oh, maybe that's hyperthyroidism because this number is high. The opposite is true because what's happening is the thyroid is not producing enough of that thyroid hormone for a number of reasons that we'll talk about in just a moment. But the hypothalamus and the pituitary then realize that, and the pituitary starts yelling at the thyroid by cranking up that TSH. So that's why a higher TSH generally indicates a hypothyroid state. Now, it's a fairly common condition. Obviously, not the majority of the population will have it, but roughly 6% of folks here in the United States will have some sort of thyroid disease. And of that percentage, the vast majority of thyroid dysfunction is indeed hypothyroidism. And we'll talk about a specific cause of hypothyroidism in just a moment called Hashimoto's, which tends to be one of the most common form of hypothyroidism. The issue with this is it does cause a number of different symptoms, many of which are generalized, which means that these symptoms, yes, they can indeed be from hypothyroidism or could be from a whole number of different things influencing those symptoms. So things like hair loss, feeling cold or what we call cold intolerance, and general feeling of fatigue, being tired all the time, having not really symptom wise, but having a higher cholesterol or having slower heart rate, or bradycardia is the other term for that. Constipation is a well-known and documented symptom of hypothyroidism. And then dry skin and bitter nails are commonly seen as well. Another challenge with this is that because some of these symptoms are very generalized, and because many of these symptoms too can just be associated with older age, it can make it a difficult diagnosis initially if proper screening is not being done for older individuals who may kind of chalk many of these symptoms up to just the old age and not realize that there is some hypothyroidism present. So here's a list of a few of the causes of hypothyroidism. Worldwide, it used to be that the most common cause is an iodine deficiency. So if you don't have enough iodine present in the body for the iodinization of that molecular skeleton to take place, well, you can't make the thyroid hormone that you need. Here in the U.S. and other developed nations where we have iodinated salts, it's very, very rare to see an iodine deficiency. But indeed, worldwide, again, that was the most common cause. Far and away nowadays, we see quite a lot of Hashimoto's hypothyroidism, which again, we'll go into some more detail here in just a moment, but it's an autoimmune cause where the body is producing antibodies that interfere with the production of thyroid hormone, specifically with the thyroid peroxidase enzyme. And then other causes, if the patient has had radioactive iodine treatment or RAI, generally for hyperthyroidism or Graves, or if they've had a history of thyroid cancer, they may have had some radioactive iodine treatment, or if they've had a thyroidectomy or removal of the thyroid, again, likely from either history of thyroid cancer or having a very large thyroid called a goiter that's causing compressive symptoms. Obviously, without a thyroid gland, you'll have hypothyroidism. Amiodarone, since we are indeed talking about Heart Awareness Month in relation to the thyroid, that's an antiarrhythmic medicine that many cardiac patients may be on, and it has a tremendous amount of iodine in it. But interestingly, amiodarone can cause both hypothyroidism or hyperthyroidism. But oftentimes, if we see a patient's on amiodarone and they come in with an increased TSH like that will raise some eyebrows as being a potential cause. Central hypothyroidism. So again, referring back to that hypothalamic pituitary thyroid axis, if you have a problem upstream from the thyroid, say namely with the pituitary, then you don't have that release of TSH that's needed for stimulating the thyroid to make that hormone. And that can be a little bit of a different beast in and of itself, but again, fairly rare, very rare compared to the others. And then, of course, iatrogenic, which means caused by the physicians or the treating provider. If they're, say, being treated for hyperthyroidism and the dose of their medicine is too high and it goes too far the other way, causing hypothyroidism, that's a potential cause as well. So a brief primer on Hashimoto's. As mentioned before, it's an autoimmune disorder with those antibodies interfering with the production of the thyroid hormone. Not only does it interfere with the production of thyroid hormone, but it causes an inflammatory process, which indeed can cause the thyroid gland to become much larger than normal, resulting in goiter. That in turn, just due from the mass effect of the gland becoming so large, can push on all the surrounding structures, most notably the esophagus, and can really cause some difficulty swallowing. If that's the case, we generally will refer people to a surgeon to have the thyroid removed, because even treating the hypothyroidism, you might have a little bit of reduction in the size of the gland, but if it's causing that much difficulty, especially with the swallowing, we generally opt to go ahead and remove and then replace the thyroid hormone that the patient needs afterwards. So zooming in a little bit further on the cardiovascular risks, if you don't have that thyroid hormone present, indeed the heart's not going to receive that input from the thyroid hormone. It results in a slower heart rate than normal, and results in less blood being moved around the cardiovascular system. In turn, or also I should say, the thyroid hormone affects the liver and how many LDL receptors are present on the liver to essentially pull LDL, which is the so-called bad cholesterol. So when you don't have those receptors present from low thyroid hormone, the amount of bad cholesterol in the bloodstream is increased, which can lead to more of the atherosclerosis, where you have the thickening of the vessel wall and narrowing of the blood vessels, thus increasing the risk of heart attack and stroke. Again, as mentioned before, thyroid hormone does affect the blood vessels, not just the heart itself, not just because of the cholesterol, but the tension or the blood pressure. You can actually have hypertension with hypothyroidism, and if it's a long-standing and more severe form of hypothyroidism, it can also lead to heart failure. We see less and less of this because of earlier screening and more recognition, but we still see the occasion, especially in training, we would see the occasional patient who had just gone months or years with very untreated hypothyroidism that had indeed taken a toll on the heart. So shifting gears from hypothyroidism over to hyperthyroidism, this is the opposite condition where you have overproduction and too much of the thyroid hormone present. And we'll talk about the different causes of why that may be. But compared to hypothyroidism, it's comparatively rare. You'll only see it in about 0.5% of the US population, though being in an endocrine practice, we certainly see our fair share. In fact, I think I saw 2 patients being evaluated for hyperthyroidism just this morning. You generally see the opposite type of symptoms with hyperthyroidism from hypothyroidism, as you might expect. Rather than slow heart rate, you'll have a faster heart rate because the heart is being stimulated by the excessive amount of thyroid hormone. So palpitations, heart racing, very common to see with clinically significant hyperthyroidism. Because the metabolism is also ramped up, you'll often see some weight loss. And due to that, you'll often see some increased appetite. The patient says, I'm eating everything in sight, but I'm still losing weight and I feel hot all the time. So heat intolerance, again, opposite from hypothyroidism, is common to see. Around this time of year when it's cold outside, it may not be as bothersome to the patient, but come summertime, they'll definitely let you know about heat intolerance. Tremors are often seen too. So when we're evaluating for hyperthyroidism, I'll often have them hold their hands out and you might see a little bit of a fine tremoring of the hands. And then again, opposite of constipation with hypothyroidism, diarrhea is typically seen because it's increasing the motility of the GI tract. In fact, the guy here on the diagram is doing some work on his laptop, it looks like, and maybe that's some of our participants here in the talk today. I don't know, with the virtual format. But hyperthyroidism and focusing on its effect with the heart. Again, we talked about the increased heart rate, and especially in older patients, that can significantly increase the risk of atrial fibrillation, which is an arrhythmia that occurs in the top of the heart where the atria are, causing them to quiver as opposed to contract fully. And what happens with that quivering is that the blood tends to pool, and when the blood is pooled and not flowing like it should, it can increase the risk of clots. And when the clots are present, that can dislodge and go somewhere it's not supposed to, resulting in heart attack, stroke, etc. So very important to avoid hyperthyroid state, especially in our elderly patients or anybody that's predisposed to arrhythmias that way. Again, the heart rate is increased. So with long-term hyperthyroidism, that can cause the heart to become over hypertrophied, basically too muscular for a heart. You'd think, with any muscle that the bigger the better, but can cause significant issues with the heart if it does have that cardiomyopathy present. And even though the heart is beating faster, the contractions may not be as efficient and can lead to what they call high output heart failure, where Heart's working hard, but it's not moving that blood efficiently, leading to heart failure. So shifting gears to treatment of these conditions, for hypothyroidism, so when you don't have enough of that thyroid hormone present, essentially the main treatment is to give the body what it needs by giving it that thyroid hormone in an oral form. Most commonly, especially in this clinic, we use a lot of generic levothyroxine, which is free T4. Synthroid is the brand name of levothyroxine. We have a number of patients that anecdotally state that they tolerate the Synthroid better. It's more of a consistent form of levothyroxine as opposed to the generic forms that can be from different manufacturers. And then there's also Tirosint, which is a capsule instead of a tablet. And that can be helpful for absorption because there are many things that can affect the absorption of oral levothyroxine or free T4. That's why I have a picture of delicious cheese. I'm a big cheese fan, as well as an iron, because calcium and iron in particular will essentially compete for absorption of levothyroxine in the stomach. So if a patient is on calcium or oral supplements, calcium or oral iron supplements, which many of our patients are, especially as you get up in years and look at osteoporosis and things like that, we often will counsel them to take those supplements at least 4 hours apart from the levothyroxine. And I usually tell them towards the afternoon or evening, kind of the tail end of the day, just to prevent any sort of absorption issues. I don't have a funny picture to show it here, but also celiac disease or anything that, again, can affect the absorption of anything in the stomach can impact the efficacy of thyroid hormone. So if celiac disease is present or any other sort of GI pathology, we want to make sure that that's addressed to, again, make sure that that thyroid hormone is being absorbed as consistently as possible. Now, there is also T3 cytomel. We have a number of patients that report symptomatically they'll feel better having some T3. It's not too often that I have to resort to that, but occasionally I'll tack that on if TSH is normalized, just again for a little bit of that symptomatic improvement. And then there are a host of different formulations that have both free T4 and T3, Armor and NP Thyroid. We have a number of patients that are on these formulations, and some of them do great. They have normalized TSH, and I'm perfectly fine to continue on that. The issue that can occur with those is it's not standardized how much T3 may be present because they're essentially desiccated pig thyroid, which is why I have our cute little fellow at the bottom there. And because it's not necessarily consistent how much T3 is present, I'll generally shy away from these, especially if I'm seeing a patient who's had fluctuating TSH values despite trying to adjust the Armor or the NP, usually with their primary care provider first. Let's talk about some of the causes of hyperthyroidism. I apologize. I think I had one of the slides shifted before. I was wanting to talk fully about hypo before shifting to hyper, but here we are. So some of the causes of hyperthyroidism, most common by far is Graves' disease, which very similar to how Hashimoto's was an autoimmune cause of hypothyroidism. This is an autoimmune cause for hyperthyroidism and tends to be, actually it's what I suspect one of my patients this morning to likely have. You can also have a hyperactive thyroid nodule where a segment of the thyroid kind of gets too big for its britches and starts autonomously producing thyroid hormone. You can have a transient thyroiditis where you have a viral illness, or pregnancy is very notorious for causing a sudden release of thyroid hormone from the thyroid, which is followed characteristically by a hypothyroid segment, which you can see in the top right corner in that waveform graph. And then after several weeks, that tends to normalize on out to a euthyroid state. Amiodarone, again, as mentioned before, that can cause both hypothyroidism or hyperthyroidism. More so the hyperthyroidism because of the high iodine content associated with amiodarone. And it can actually do it through two different processes, either a type 1 amiodarone-induced thyroiditis or AIT, where it's more of an autoimmune association or overproduction of thyroid hormone with the iodine, or it can cause more of a type 2 AIT, which is a more destructive process where it's destroying thyroid tissue, which in turn is releasing thyroid hormone. But we won't go too deep in the weeds there. There's also an extremely rare form of TSH-OMA, which is a pituitary mass. Again, looking back at that hypothalamic pituitary thyroid axis, if you have a mass on the pituitary that's over-releasing that TSH, then that could be overstimulating the thyroid. I've never seen one in practice, but they've been documented, so it's a cause. And then, of course, iatrogenic. If we're treating a patient for hypothyroidism and we have them on too strong a dose of the levothyroxine, then of course we can go too far the other way and suppress that TSH, causing them to be hyperthyroid. Many times when we're trying to parse out what the exact cause is of hyperthyroidism, we'll undertake a radioactive uptake and scan where we'll have the patient go into an imaging center. They'll take a small dose of radiotracer iodine, and then they take a picture of the thyroid to essentially see how it's absorbing that radiotracer iodine. You can see a normal thyroid gland in the center superior part there. In Graves' disease, which is that autoimmune form where the entire thyroid is just being overstimulated by antibodies, you'll see a globalized increased uptake, which is why it appears so much darker. In that thyroiditis situation where I mentioned it may have that hypothyroid state after that initial dump of thyroid hormone, you'll actually see decreased uptake, which is what you see on the right side. You can see a cold nodule. That's less so for the hyperthyroid. If you see a cold nodule, that can be suspicious for thyroid cancer, and oftentimes we'll get that biopsied. The hot nodule that you see in the bottom center there, again, would be that hyperactive thyroid nodule, and those are almost universally benign, interestingly enough, in terms of not being cancer. But that will influence our treatment decision. And we'll talk more about it in just a moment. But with a hot nodule, while it can be treated medically, it cannot be cured medically. Whereas Graves, there's about a 50% chance of remission once it's controlled on medical therapy or pills after about a 2-year time frame. And then lastly, if you have multiple hot nodules, what's called a toxic multinodular goiter that you see there on the bottom right, where you have multiple sites of overproduction, again, that leads us as to, or gives us information as to the cause of the hyperthyroidism. So Graves is the most common form, and I know this is a bit of an eye-popping slide, but what's interesting with Graves compared to all those the other forms of hyperthyroidism is that because those antibodies are present, those antibodies, again, they're all over the body, and they can cause inflammation, not just with the thyroid, but also with the tissues, the fat, the muscles, and so forth that sit behind the eye, which you can see in that diagram at the bottom there. It can cause swelling and inflammation, which cause the eyes to be pushed forward and protrude, called exophthalmos, and causing that characteristic kind of bug-eyed look. It can also contribute heavily to thyroid eye disease, which is very bothersome to patients because of kind of a scratchy, uncomfortable feeling the vast majority of the time. And that can occur even after resolution of the Graves. Say the Graves was extreme and we had to have their thyroid taken out to cure it because medicine may not have been sufficient. Even after the TSH is normalized and functionally their body is receiving the thyroid hormone fine from levothyroxine, this thyroid eye disease can still persist because those antibodies can still be present, causing that retroorbital inflammation. So usually, if we suspect this, we'll refer the patient to our friend, the ophthalmologist, the eye doctor, who may consider Tepezza, which is a medicine that can help with thyroid eye disease. So talking about how we treat hyperthyroidism, there's a couple of medicines that have been around for a long time that do tend to work well, called methimazole and propylthiouracil, or PTU. We tend to use methimazole far more commonly than PTU unless you're in the first trimester of pregnancy, because methimazole has a little bit less risk of causing liver inflammation, or elevation in liver enzymes called transaminitis compared to PTU. But PTU has been shown to be a little bit safer in the first trimester. So that's basically the only situation where we might use that instead of methimazole. We tend to get good success rate using medical treatment. What that medicine does is it's kind of like thyroid peroxidase antibody that you see in Hashimoto's, where it will inhibit that thyroid peroxidase enzyme, which is involved in thyroid hormone production. So it's basically just cutting down on how much hormone the thyroid can produce. And then oftentimes when we diagnose hyperthyroidism, the most bothersome symptom for many patients is that palpitation, the fast heart rate. It makes you feel very anxious. It makes you feel like something's wrong, episodically or even all the time. So we'll typically prescribe beta blockers, which slow heart rate. And we try to get their heart rate, certainly less than 100 and ideally less than 90. But that's more for the symptoms and not really addressing the underlying cause of the hyperthyroidism. In more severe cases where we may not be getting sufficient control with the medicine alone, or if the patient doesn't wish to take medicine all the time, they're kind of in a catch-22 there, because if you do undertake radioactive iodine or surgical treatment, you do have to take levothyroxine replacement therapy, from that point on. I've rarely used radioactive iodine therapy for many of my patients, especially if they have the thyroid eye disease, because oftentimes that will exacerbate and worsen thyroid eye disease. Most of my patients who we can't get control with the medicine alone will opt to have an ENT, ear, nose, and throat surgeon go ahead and take the thyroid out in that case. So who do we worry about having thyroid dysfunction? So if the patient has had a significant family history, lots of siblings, parents, of course, with thyroid issues, it does tend to run in the family. Female patients are far more likely to have a lot of thyroid dysfunction, particularly Hashimoto's hypothyroidism we see with a greater prevalence in our female patients. And then with age as well, these issues tend to arise, especially after age 60. And it tends to be seen more in Caucasians than other races, but we've seen them in all races and in all genders too. It just says that it might be a little bit more common in those. And then certainly autoimmune disease tends to run hand in hand with other autoimmune disease. So in our folks that do have other autoimmune disease, whether it's rheumatoid arthritis, pernicious anemia, Addison's, whatever, then they're going to be at an increased risk of having autoimmune Hashimoto's or Graves' disease. Zoning in a little bit as well, and we've kind of talked about it some before, but whether you have hypo or hyperthyroidism, that does put a strain on cardiac function, whether it's with slower heart rate or increased heart rate. It essentially impacts the efficiency of the heart to move that blood around the body. And it also significantly impacts the blood vessels. We talked about that LDL, bad cholesterol, being increased, particularly with hypothyroidism. And all that can significantly contribute to CVD or cardiovascular disease, thus increasing cardiovascular mortality risk. Now, what may be more important for our audience today is subclinical forms of these, where maybe somebody's not really experiencing many of these symptoms, but their TSH or that lab value may still be mildly off. So there's good evidence and research that suggests treating these subclinical forms of hypo or hyperthyroidism can be very important for preserving cardiovascular health. So if a TSH is just mildly elevated, so mild hypothyroidism between 4.5 and 7, because a normal TSH in general is seen between 0.5 and 4.5, then we may consider treating the patient, definitely if they have hypothyroid symptoms. If they already have significant cardiac risk factors and they already have some higher cholesterol, I typically start some levothyroxine in a patient like that. If it's above 7, absolutely, I tend to start levothyroxine. I tend to be a little bit more cautious on starting someone who's only mildly hypothyroid if they are elderly. because the risk of kind of kicking them hyperthyroid is increased, and hyperthyroidism transiently is much more dangerous for cardiac function, again, for those arrhythmias that we discussed before, compared to mild hypothyroidism. And then with subclinical hyperthyroidism, as we just discussed with the atrial fibrillation and issues with arrhythmias, if somebody's just mildly hyperthyroid with a TSH between 0.1 and 0.4, again, if they do have a history of some of those arrhythmias, I would generally treat just to, again, drive that risk down as much as we can. And then if it's less than 0.1, I generally will start methimazole regardless, just to reduce that cardiovascular disease risk. They've done a lot of meta-analyses and studies over time. With hypothyroidism, even if it's subclinical, it can increase the risk of cardiovascular disease by, I believe it was 80%. And many studies have confirmed the long-reaching impact of remaining subclinically hypo or hyperthyroid on cardiovascular incidence and cardiovascular-related death. I threw a couple of case studies here at the end. Don't worry, we're not going to go too far in the weeds. We're actually doing pretty well on time. But I wanted to kind of give you all a picture of what we typically see here in the clinic with these usual presentations. The first study is regarding hypothyroidism. So we have a 60-year-old female that comes in. She's got many of those symptoms we talked about before, with weight gain, dry skin, constipation, depression, and that cold intolerance. Her heart rate's a little low at 53. She's got a little bit of swelling around the ankles, that mild pedal edema, which can be concerning, that the blood may not be moving quite as efficiently. She doesn't really have a known family history of thyroid issues. She's got a history of some high blood pressure. So we get some blood work, and her TSH indeed is elevated, 12.5, well above that 7.0 threshold that we mentioned a slide ago. Her free T4 measurement, the direct measurement of that thyroid hormone, was also low at 0.7. And she does have some elevated cholesterol with an LDL level of 165. Triglycerides also mildly elevated at 180. They do a echocardiogram or an ultrasound of the heart, and they do see a little bit of reduced ejection fraction there. And of course, they see that slow heart rate on her ECG. So it's pretty clear hypothyroidism, again, with that elevated TSH and those textbook symptoms there. So we would start treatment with some levothyroxine, giving her body the hormone that it is evidently craving. And we would then adjust the dosage of that levothyroxine every 6 to 8 weeks. Now, you may question why that's a lot amount of time. It actually takes about 6 to 8 weeks for that hypothalamic pituitary thyroid axis to retool itself, basically for the TSH to respond to that medication. And that's why we wait 6 to 8 weeks to then make a dose adjustment if necessary. We would expect that her LDL would improve. We'd expect that she would have less fatigue, certainly that her heart rate would normalize, and we might even see improvement in her heart efficiency, where hopefully that pedal edema would resolve. So that will bring us to case 2, which would be the opposite with hyperthyroidism. We'd have a comparatively younger guy, 45-year-old, coming in. He's having some heart racing, some palpitations. He's had some weight loss, sweating or heat intolerance, some tremors, anxiety, all the textbook stuff. He has a mother that's had a history of Graves' disease. We get some blood. His TSH is indeed undetectable. Free T4 is elevated at 2.5. Total T3 is elevated at 310. And we get the antibodies for Graves' disease called TSI, which is indeed positive. So clear-cut diagnosis, we would then give him some beta blockers to help with those palpitations and those bothersome symptoms. And we'd start him on that methimazole therapy. And depending on how he responds to that medical therapy over the next few weeks or months, we can either continue on that for 2 years to see if, again, he might be one of the lucky half that would go into remission of Graves, which, again, there is a risk of recurrence, and roughly 60 to 70% of folks that go into remission might have Graves again later in the future. But we can do that, or if indeed he does not respond well to the methimazole, if he just remains hyperthyroid, we could look at definitive therapies with either radioactive iodine, presuming he doesn't have any of the thyroid eye disease, or surgery to remove that thyroid. Regardless of whether it's medical or surgical, we would expect him to be much more comfortable without those palpitations and anxiety. His heart rate should be much more controlled, and overall feeling much more comfortable without the concomitant cardiac risks associated with that. So issues are, diagnosing folks that may have those symptoms, but may not be thinking it could be from the thyroid. It's always important with your primary care doctor, or if you're already seeing an endocrinologist, to have that TSH checked periodically. And we recommend at least annually. And if there is thyroid dysfunction, of course, much more frequently than that until it's normalized on therapy. And it can be a challenge as well to find that correct balance with the medication, most notably with hypothyroidism, because, as mentioned before, with the calcium and the iron and the absorption issues that can interfere there, sometimes, you'll have fluctuation, and it can be a challenge to find that correct dose. And that dose can also change over time, particularly if you've had significant weight loss or weight gain. That will impact how much thyroid hormone is needed in someone who's being treated for hypothyroidism. I believe that's the bulk of the presentation. We finished in good stead. Hopefully left a few minutes for folks to have some peace and quiet with lunch. If anybody has any questions, of course, now's the time.
Okay. Thank you so much, Dr. Grissett. That was very informative. Great content, great information. While the audience is getting their questions together, I'll go ahead and start out. Is there anything that we can do if our thyroid is in normal range right now, but to continue to maintain a normal level? Like you mentioned, with age, over 60, it's common that hypothyroidism could develop. Is there anything that we can do to prevent that?
It's a good question, and especially on the market too. They have all these thyroid hormone, thyroid health supplements that are available, oftentimes containing, iodine or selenium. There are studies out there that selenium can be helpful if there's like a family history of Hashimoto's or a personal history of positive Hashimoto antibodies, but still with normal TSH. The selenium can be helpful. Quite frankly, though, you can get the selenium quite easily from your diet. I think a lot of the thyroid supplements that are pushed on the market are kind of expensive and don't really add much benefit, to be frank. For the selenium, for instance, you can actually get the daily requirement from 3 or 4 Brazil nuts a day or so. You don't need to buy an expensive selenium supplement or anything like that. What I would recommend more so than necessarily taking a supplement is, again, having that necessary screening annually or so, or if you're having some of those concerning symptoms, with your primary care doctor, because there's far more data, and two, there's a lot more information on the efficacy of using thyroid hormone when it's needed, especially in the context of clinically significant hypo or hyperthyroidism with methimazole. So no, I wouldn't recommend supplements. I would just recommend screening, especially if symptoms are present, or if there's that significant family history of either thyroid disorders or autoimmune disease.
Great, thank you. I believe I saw Dr. Renfro. If you want to unmute, I saw your hand raised.
Well, you were asking basically what I was going to ask, Jackie. So
Okay.
I think I believe it was with the hypothyroidism, there was a mention of a heart healthy diet and introducing physical activity. But I think from the sounds of things, a lifestyle of that's not necessarily going to help prevent these types of illnesses. So that was more my question.
Yeah, in response to, I guess, the causes of hypothyroidism, many of them are sporadic, aside from, again, the autoimmune forms, which can run in families. So in terms of diet, no, there's nothing specifically that needs to be done, aside from making sure you have enough iodine, but we tend to not have an issue with that again in here in the developed world. We don't have a problem getting our salts in for sure.
Mhm. What about with those who have been diagnosed with a thyroid disorder and now they're on medication, to treat that, either hyper or hypo? Does that mean they're on medication for life?
Largely, yes. It is case by case. Certainly, if it's hypothyroidism, then the vast majority will be on some form of thyroid hormone replacement indefinitely, if not lifelong. The instance where I would see medication being used for a temporary time frame would be for Graves when they require that methimazole and can experience remission, 2 years hence. Again, there's about half folks who will have remission, and of those, roughly 40% will stay in remission past that point. But even in those, as you might have imagined, we keep a close eye on. We get a TSH measured at least annually, if not every 6 or 3 months, to make sure that their thyroid's still performing like it should.
Dr. Grissom, I had one more question based on that, and I'm not sure that my sister-in-law had Graves, but she had the bulging eye issue, and watering eyes problem and the bulging eye problem. And looking back on it, sounds like it could have been Graves, but I don't remember knowing the details of it. And it does appear to be in remission. And I will say at the time that she was going through this, she was experiencing an extreme level of stress with some family members. Do you see stress as something that can exacerbate or help bring on something that might be there? Is stress related to this at all?
Certainly in terms of an autoimmune process, not necessarily with, stress with impacting that hypothalamic pituitary thyroid axis, but stress in general can exacerbate autoimmune conditions. It does trigger the inflammatory response in the body, which in turn increases those antibodies. So in fact, I'm a type 1 diabetic, which type 1 diabetes is a form of autoimmune disease. And in many cases with type 1 diabetes, there will be some sort of viral insult beforehand, not all of them. In my case, there was no viral insult, but extreme stress beforehand. This was in like my college years, which everybody stressed in college. And that was really the only link that we could think of leading to the development. So to answer your question, stress certainly can contribute, but not in a direct sense on that axis.
Mhm. I see some typing going on, so there's some questions coming in. In the meantime, I'll ask this one. Can you speak a little about Tepezza and the treatment of the bulging eyes with Graves' disease?
Sure. So Tepezza is an infusion. It essentially works by taking out the antibodies that are associated with Graves that are causing that retroorbital inflammation. We don't use it really here in the clinic so much because, again, we need our ophthalmology colleagues to lay eyes on it, no pun intended, and they generally will go ahead and schedule the infusion. I'd have to look at the precise dosing schedule for Tepezza. I know it does involve a few different infusions. I believe it's less than a year total in terms of treatment, and they do see different rates of success. It may not completely, cure or take away the thyroid eye disease, but clinically, or it does have a clinically significant difference in improving those symptoms.
Thank you. There's a question that just came in. What could cause high heart rate in a Hashimoto's case? Sorry, mispronounced it.
Well, the heart rate, it's influenced by a lot of different things, even outside of the thyroid. In terms of Hashimoto's, I would suspect if they have tachycardia and or fast heart rate and a few other symptoms that they may be being overtreated, presuming that they're on levothyroxine, because again, you'd be kind of pushing them into a hyperthyroid state. If that's not the case, then I would chalk it up to a cause that's outside of the thyroid. And that's a good question, because one of the frustrating things, particularly with hypothyroidism, is that even once we get the TSH normalized, which is actually our therapeutic goal, because there's a lot of studies saying, if you overtreat and push them into that hyperthyroid phase, a lot of people feel pretty good with a suppressed TSH, especially if they've been hyperthyroid and they're sick of being tired all the time. But because, as we talked about on the subclinical hyperthyroidism, because it does cause increased stress on the heart and on the bones and on the GI tract and a lot of other systems that we didn't zone in on with this presentation, we do not, we don't go by symptoms alone in terms of treating the hypothyroidism. If the thyroid TSH is normalized and they're still having symptoms like that, oftentimes we have to look at underlying causes, such as you mentioned, stress is a big one, anxiety, depression, any other comorbidity that's contributing. In fact, when I was doing training, one of my favorite preceptors, she may not have been the most sympathetic of sorts, but she had a sign in her office that said in big bold letters, "It's not your thyroid," because she would have a number of patients who unfortunately would have these persisting symptoms despite having a normalized TSH. And it's frustrating for the patient. It's frustrating for the provider. So oftentimes when I see somebody for the first visit, I set expectations and let them know that likely will happen. Like, the symptoms can persist despite having that TSH normalized. And oftentimes that really does help, again, set those expectations and set the stage moving forward.
Very interesting. Let's see. Okay. Trying to see if I see any more. Chat isn't working. Okay, last call for questions from the audience. We've got a great attendance today. You're getting some kudos there, Dr. Grissett. Very informative. Thank you so much from comments that are coming in. One question I just see that allergies. Could your thyroid cause existing allergies to get worse?
Not to my knowledge. That would kind of be more, the allergies would be more under the purview of our ENT associates. And I assume, they may be referring more like a seasonal allergy.
Probably. The person that sent that question in, if you want to respond back in the chat to elaborate, is that seasonal allergies or like allergies to like particular food allergies or something like that? As they're no to seasonal.
Okay. In general, I would not suspect it to. No, I wouldn't think that thyroid disease would necessarily, increase or worsen existing allergies. Again, autoimmune disorders tend to run hand in hand. So the fact that you do have some allergies, again, has the activated immune response, which can worsen autoimmune diseases. So it's not a great answer. To be frank, I don't know precisely if there's an association with allergies, but my suspicion is not, and I say that just because in my clinical practice, I haven't really seen that association.
Again, lots of comments coming in from our members. Thank you so much. Awesome presentation. Appreciate you sharing your expertise. Wonderful session, very informative. Thank you for your session. I love the humor. So you got a lot of great comments out here. Very informative. So thank you all for attending, and most importantly, thank you, Dr. Grissett, for your time and for sharing your expertise with us today. We're just so thrilled to have this important topic addressed on thyroid health. So you've given us a lot of valuable information for us, and we can also share with others. So we really appreciate it.
My pleasure. I enjoyed it. Everybody have a great rest of your day.
You do as well. Thank you. All right, everyone. Thank you so much. We are still going to do a drawing for our heart healthy cookbook today. And let's see.